sounds like they are all set. So we are going to go ahead and get started. So, hi, everybody. Welcome to Happy Friday, first of all, and welcome to this conversation. We are thrilled at NC Child to not only be partnering with NC Child Treatment Program, but also to have an opportunity to talk a little bit more with them today. So we have Margaret Samuels with us. I will let her introduce herself, but first of all, I just wanted to say thank you. Felipe did go through the instructions for recording, for interpretation, so you should be able to find that in the globe on the bottom of the screen. And in addition to that, I'd love to introduce myself. My name is Cassandra Reisick, Policy Director at NC Child. We have our Health Policy Manager is on vacation right now, so she will be joining us. She'll be joining us at our next Lunch and Learn, but just wanted to say thank you to each and every one of you for being here. And I see that we might need to get the chat available. So I'm going to go ahead and make sure that that is available for folks too. Thanks, Jenny, for sharing that. All right, y'all. And at this point, I'm going to turn it over. I'm going to turn it over to Margaret.
Great. Cassandra, thank you so much. And thank you so much to NC Child for inviting the North Carolina Child Treatment Program here today. And thank you so much to our interpreters. We so appreciate that. And Cassandra, I think you said you would be monitoring the chat in case anything comes up. Super. It's so nice to be here today. My name is Margaret Samuels, and I'm the director of the North Carolina Child Treatment Program. My colleague Ada was to join us today, but she is our manager of outreach and recruitment, but unfortunately could not be here today. But I am excited to be here and share our program with you. Oh, there we go. Whenever I'm advancing slides, I always have a little bit of a panic that it won't go, but there it did, it went. Ada helped me create an agenda today so that we could describe our program to you, and hopefully there'll be a little bit of time to answer questions. We have a few things that we want to talk about, just maybe a little bit about the history. Some of you may know how the program started, what our main goals at the North Carolina Child Treatment Program are, and what we do that is set forth in legislation by the North Carolina General Assembly. And then hopefully we can talk a little bit about ways to collaborate and answer any questions. First, the North Carolina Child Treatment Program really began in 2006. And it started not with funds, not with allocated funds from the General Assembly that would eventually come in, thankfully so, in 2013, but originally with some private grants and some assistance from Alliance Health and some of the MCOs. And it started with one model, one evidence-based model called trauma-focused cognitive behavioral therapy. And the North Carolina Child Treatment Program is housed under the Center for Child and Family Health, which is a nonprofit in Durham, North Carolina, that originally started in 1996 as a collaboration of the three area universities, Duke University, UNC Chapel Hill, and North Carolina Central University, with Central providing legal assistance and guidance to the program. And it was several doctors, pediatricians, and psychiatrists that started this center because they realized in doing child medical exams for abuse that there weren't a lot of places that specialized in treating children who had been exposed to trauma and their families. So the center began with that goal. And then as time passed, it was obvious that there were many treatments that were being developed or had been developed that could treat trauma very effectively. These evidence-based cognitive behavioral models that gave a lot of direction, were time limited, and could really address trauma symptoms. And so in 2006, after several people at the center learned TFCBT, we started training in the eastern part of North Carolina, mental health professionals and agencies in TFCBT. And then the program grew from there. And in 2013, we received an allocation from the North Carolina General Assembly to train licensed mental health clinicians in evidence-based models, and to also work with the MCOs and insurance companies, and to also, which we'll talk a little bit about a little bit later, there's a slide, to maintain a roster of high quality evidence-based trained clinicians so that programs, DSS, families, places that needed to refer families and children to providers who provided these models. And we'll talk a little bit more about the individual models. Just a quick, this is our management team at the North Carolina Child Treatment Program. And so we do invest time and support, as does the state, in not only training in the evidence-based models, but evaluating them. We evaluate as we go. We submit data to the state so they can see the effectiveness of each of the models. And we also assist agencies when they're enrolled, when their clinicians are enrolled in their training, in how to implement an evidence-based model at their agency or private practice. Again, our mission really is to strengthen the mental health workforce in North Carolina and change children's lives. So that really was what we were directed to do, to really help to make a difference for children with mental health treatment through the workforce. Our approach really takes three paths. As I noted, one is training, in-depth instruction through the Learning Collaborative model, which is sort of classroom training, virtually or in person, and then continued follow-up, whether that is individual or group consultation, while seeing cases while you're training, so that experienced national trainers who have spent many years providing the model to children and families also provide that coaching to the trainees who are learning that model. And then we have an implementation arm to what we do, where we meet with agency and practice leaders to help them figure out how to implement the model throughout their agency and practice, what barriers they might face, what billing looks like, and how to maintain that model. We do some work, some advocacy statewide, particularly in amplifying the voices of our trainees around rates at the MCO and in insurance agency level. And then with our main focus being the workforce development, both supporting the workforce while they're going through our training, after they have trained, and then most recently, supports, dedicated supports around burnout and secondary traumatic stress. Just to talk a little bit more about the Learning Collaborative model, it was developed by the, or utilized mainly by the the National Child Traumatic Stress Network, NCTSN, of which our agency, the Center for Child and Family Health, is a part. It provides the in-depth instruction, follow-up consultation calls, individually and group-wise, and then again, the agency support. Let's talk very quickly or briefly about the different models that we have. So we've sort of divided up the different models that we train in. So our early childhood models, those tend to be for children birth to about the age of 6. Child-parent psychotherapy and parent-child interaction therapy. Child-parent psychotherapy is the one that is, and I'll talk a little bit more in a second, is the one that is utilized with the Safe Babies Court program, which we'll talk about. And that is an attachment and trauma-focused model. The training for that model is among our longest models. It's about 18 months. And that we work with families where they have infants 0 to 5 and their caregivers. Parent-child interaction therapy is a specialized behavior management model. We train in that. We have, for both of these models, we do 2 learning cohorts a year of clinicians across the state. In parent-child interaction therapy, that is a model some of you may have heard. It utilizes sometimes a two-way mirror, sometimes listening devices where the clinician is coaching the family through the actual treatment. It's one of the most, both of these are highly studied and have a lot of evidence to show that they assist with behavior management, child-parent psychotherapy, particularly with attachment and treating symptoms. Parent-child interaction therapy is one of the most studied models of all of our models that shows very good effectiveness. Oh, here we go with our Safe Babies initiative slide. The state of North Carolina for the past few years has been engaged with the 0 to 3 national organization in implementing Safe Babies Court initiative. And that is an intervention that works with the Department of Social Services, the courts, local stakeholders, and families who are at risk at risk or involved with child protective services and at risk for potentially losing custody of their children. And so what Safe Babies Court attempts to do is to work intensively with the families, both on the court side and in what the families may need in collaborating with DSS and the community to avoid that and make reunification possible and to avoid disruption with the family. Child-parent psychotherapy, although not the only model of mental health treatment that is used in the Safe Babies Court, it is a model that is often used in Safe Babies Court initiatives across the nation, actually. And in fact, one of the trainers that we have at our center, we have 2 national trainers in child-parent psychotherapy. One of them works for the state of Maryland Safe Babies Court initiative. Not every state implements Safe Babies Court exactly the same. But in North Carolina, Safe Babies Court initiative, there is a statewide working group, is implementing pilots in several counties around the state. And they have decided to invest resources in training clinicians in these pilot counties in child-parent psychotherapy. So we work closely with the courts teams, with the families doing this treatment. And we have been fortunate for the past 2 years to be working with this statewide initiative. I'll just mention our school age or school models that we are focused on. One is actually, and I didn't mention, we received at the beginning of July 2024 expansion dollars from the DCFW at North Carolina Department of Health and Human Services to expand the models that we are training in. Out of the $80 million that was allocated to DCFW for Medicaid expansion in North Carolina. One of the models that we added because of that expansion is Bounce Back. And Bounce Back is a model that can be done in schools from kindergarten to fifth grade. It is a group-based model with some individual sessions as well for the child and the family member, the caregiver. We also have a pilot that started several years ago in problematic sexual behavior, cognitive behavioral therapy. And that's an evidence-based treatment for children. And I say it actually has a school age component and an adolescent component. And it's divided into those two age groups of 6 to 12 and then 13 and up. There's also a pre-K modality that can be done. And that's for children who have engaged in problematic sexual behaviors. We have been working with school systems, with DSS, with the courts, with juvenile justice around this particular model. And we have been doing Nikki Crotu Johnson is our clinical director of that model, and she does a lot of education statewide about problematic sexual behavior, some of some of the misunderstandings around that behavior, and what not only in training about the specific model, but also in some of the complex behaviors that can be seen across systems, in school systems, at home, and working with families around those behaviors. And then we have our models for various ages. We've got quite a few models since the expansion, so I'll try to go through them very quickly, and then we can talk more specifically if people have questions. Again, another expansion model, Attachment Regulation and Competency Framework, ARC. That really is a framework model that focuses on caregiver parental engagement. And again, this was a model that our agency, the Center for Child and Family Health, had been doing for many years, that has great success with caregiver engagement, which was an area that many of our trainees and our agencies often talked about, sometimes as a barrier for treatment. So we wanted to think about a framework or a model that could help us address that. Cognitive processing therapy. That is a model for older adolescents, 13 and up, and caregivers or adults. It is a 12-session model that targets very specifically trauma symptoms. This we piloted and are now continuing to do CPT. We want to give a huge shout out to the CACs of North Carolina. They got the original funding to implement training in this model with the idea of being able to work with caregivers in order to address some of their trauma, so that engagement and any barriers that were there for their child's trauma could be overcome. Where we have, we've been collecting data for the past 3 years, because we got the funding 3 years ago. And we are seeing some of that impact as we are doing that model. Structured psychotherapy for adolescents responding to chronic stress, or SPARCS, again with TFCBT, which we'll talk about in our second, are probably among our two oldest models that we've been doing from the beginning. SPARCS is for middle schoolers and high schoolers, and is primarily done in the school setting, although agencies that contract with schools will also run groups in their clinics sometimes. So community-based clinics, mental health clinics, can also do SPARCS. But what we have seen over the past few years, that it's many school districts that are training in this model. Which really it's a group model for adolescents that focuses on reducing stress, for their interactions in school and with their family or their caregivers. I keep referencing trauma-focused cognitive behavioral therapy. It's probably the most well-known and the one that we have been doing the longest across the state. Um, of our roster, we have about over 700 clinicians currently on the roster. Probably somewhere from about 350 to 400 of the clinicians on there are trauma-focused cognitive behavioral therapy trained. So that would be the most widely disseminated model of all the models we have discussed. And that is, again, a very studied model that shows a lot of really good evidence for children and families ages 3 to 18. And then another expansion model, written exposure therapy, is that training is done by the same people that do our cognitive processing therapy. And that is a 5-session model. There was a New York Times article about it, but it shows some of the same outcomes for trauma reduction that cognitive processing therapy does in an even shorter time. The majority of those 5 sessions, and that is, and I'm sorry, I think I made a mistake. Cognitive processing therapy is for 14 and up. Written exposure therapy is for 13 and up. And what they find in written exposure therapy is that they spend about the client spends about 30 minutes writing about the trauma, and then the rest of the time processing it with the therapist. But we are seeing significant reductions in trauma symptoms over those 5 sessions. So the application for that, of course, a 5-session model, particularly for older adolescents or caregivers who also have younger children, has a lot of implications. So we are hoping that this will complement all of the other models. And then new this fall, we have AFCBT, which is a model called Alternatives for Families. And this model is specifically for families, for children who've experienced physical abuse or neglect. And it incorporates the parent who has engaged in those behaviors in the therapy. There are a few people actually that train across the state, across the country, but there are a few people that train in North Carolina, and we are so excited to be part of that expansion. And this model will be doing the first learning collaborative in this model for clinicians in the fall, starting in October. And I just have a few more slides. So to talk a little bit about our advocacy, we work a lot with mental health clinicians in training with their agency administration. And one of the things that we know is that evidence-based models are very effective, but sometimes they can take a little bit longer for training, a little bit longer for planning, and because the best outcomes come when you follow the training that you received as close to that as possible, which we use the word fidelity for that, which is what our trainers monitor. They monitor the clinician trainee's fidelity as they're learning the model. The closer you stay to that fidelity of doing the model as the developer intended, the better the outcomes for clients. What we know is that sometimes the funding isn't always there to maintain that. So that became part of what we, along with our trainees, do a lot of education about what that is. And we have what we call time models that we've worked with the mental health community clinician community on in developing how long does it take for preparation, how long does it, take in treatment, and what that means for billing insurance or billing Medicaid, and how we can advocate and assist programs in being able to draw down those funds. And then our other piece, again, that is in legislation, is having our statewide roster. And in fact, part of the expansion from the state of North Carolina allowed us to have a more, what's the word I'm looking for? Just a better way to do the roster, actually, to make it more interactive, so that it could be more real time, so that clinicians that are on the roster, that have been through our trainings, reached fidelity, can be in real time, letting us know if they're taking referrals, letting us know if they've changed addresses or where they are, or if they have a new county that they are providing services to, in the hopes that this will make it easier for children and families to be able to get help. We have over 750 rostered clinicians. We have advanced search capabilities, and we currently do an annual update. And we will continue to do an annual update, but now with our expansion starting this year, clinicians will have the ability to update at any point during the year, which they didn't have before. So if somebody, yes, they're so excited about that. So if somebody changes practices or agencies or whatever it might be. So that was something that we heard feedback on for years about that. You'd find a clinician, but they had moved, so we are very excited to be able to do that. So again, we thank the state for providing the funds for us to do that. And then just a quick few slides, just to talk a little bit more about our workforce development, although a lot of these things are sort of integrated across all of the areas. So whenever somebody trains with the North Carolina Child Treatment Program, we always are open to keeping an ongoing connection with them. So in most of our models, we do graduate calls. Sometimes that's formal. We do a monthly group. Sometimes it's informal, some of our other models where people want to do a one-on-one conversation. Years after, I have this case and I've never faced this before when using this model. We are sort of always there to do consultation on that. We also, several of our staff, North Carolina Child Treatment staff, got training in CSERT. And I'm going to have to talk to Ada because she didn't write out CSERT for me. And of course, when on the spot, I guess it's always hard, but CSERT is, and I'll drop that in the chat, but CSERT is a model developed by Dr. Brian Miller, and it addresses secondary traumatic stress and burnout among the mental health workforce. What's wonderful about the model is that you can use it anywhere, actually among caregiving workforce. So Dr. Miller has used it with Department of Social Services, with hospitals. We have been primarily focusing on the agencies that we serve, and it can be anyone in the agency. It's flexible enough where we can do some focus specifically on clinical staff, but all staff, from administrative staff to QP staff, can benefit from CSERT. And we do the same learning collaborative. Of course, it's different from our evidence-based models of treatment, in that, of course, we're not treating clients, but we do do a learning collaborative around it for supervisors. We do 10 monthly calls. And it's the state, again, DCFW has invested some funds in us providing this statewide to assist with workforce secondary traumatic stress. So we are hoping that it has the outcomes that I think Dr. Miller is seeing in other states. And then we do an annual evidence-based treatment conference and have for the past 5 years. And so we try to bring back all of the clinicians that we have trained. People can get AHEC and CEU credits. We do if there's any updates for the models, we bring in speakers. Our speaker this past April was one of the ARC trainers who focused on caregiver engagement. We had some feedback from some of our previous trainees that it was one of the best keynotes they went to, and they really learned some new skills in trying caregiver engagement. So that was very exciting for us to hear. We try to bring in speakers that will help trainees. We had a session on AI in mental health and ethics, to, updates in the parent-child interaction therapy manual. So we try to provide that as well. Oh, she did write it out. There was another slide. Yay, Ada. Components for enhancing clinician engagement and reducing trauma. And again, we are probably on our 5th cohort or training of this model, and we can send out more information about it. What we hear from trainees that have done this or been through it, it's not that there's anything that is so new. And in fact, some of the things people have heard, but it is a way of framing how you think about secondary traumatic stress and burnout that we have found that many trainees find engaging and helpful. And just very quickly to wrap up our milestones, as Ada points out, we grew rapidly and continue to expand. We've highlighted, density of where clinicians have been trained. Our expansion dollars that we got July 2024 were to hopefully focus on more rural and underserved areas. Underserved areas being looking at how many trained clinicians in a model and trying to recruit and outreach more for those models. So that's the intense focus over the next 3 years. Also expanding our implementation track, because we understand the challenges with funding, billing, and sustaining an evidence-based model within agencies and practices. And yearly, about 3,000 EBT clients are served by rostered clinicians in the data that we keep. So we couldn't do any of this without the wonderful clinicians that are trained statewide in North Carolina, and they do amazing work with families. So we appreciate them to no end. Here, just a highlight of some of our partnerships. Child First, who some of you may know, that is an evidence-based model. And many agencies work with Child First. They also utilize child parents psychotherapy, CPP, which is the same as the Safe Babies Court initiative. So we work with Child First agencies in providing that CPP training as well. And key to CPP, again, just to reiterate why you hear it coming up so much, especially in early childhood initiatives, is that attachment piece. It is very focused on the attachment between the caregiver and the child. And there we go. And I think we just have a last slide about hoping, that we can, and maybe have a brief discussion about working together and sharing information and connecting. We hope that can be the case. And I truly appreciate you listening to me today, and would love to leave time for questions or discussion.
Amazing. Margaret, first of all, thank you so much for not only going in depth and sharing about all the work that y'all are doing, but what the opportunities are and kind of laying out the vision for what y'all are working towards. So really appreciate that in this space. We do have a question, and then I have a couple questions as well.
Sure.
So I'm going to go ahead and jump in with our first question. So one of our participants has asked, how can the NC Child Treatment Program model, specifically looking at CPP and PCIT, got a lot of acronyms there, so apologies for that. But how can that be leveraged to strengthen the infant and early childhood mental health services under
Mhm.
Part C of IDEA, and particularly in supporting trauma-informed family-centered interventions?
Yeah, absolutely. That is a fantastic question. And we do, so both of those models, the trainers in those models, Donna Potter and Darden White does our PCIT. They work very closely with CDSAs, with statewide infant child mental health, and with DSSs as well, to ensure that not only that there's, we're continuing to train people, but those that are already trained, that people have access to them. Part of the Safe Babies Courts initiative, we've been trying to work closely across the state with any agency, any practice, any group, any stakeholder that is connecting with early childhood. So we're encountering lots of agencies that are focusing on early childhood. And then making that connection, making sure that people know the resources available for the training, and also trying to find funding to provide the training. So Safe Babies Courts currently is funding free slots in CPP training. We also have another initiative at the center called Arch, and that is headed up by Dr. Mary Wise, and that we have currently open and free slots for that model. And Mary actually works very closely in connections with the early childhood system in North Carolina to connect. So we are, as the training platform, always open to that connection and trying to train people in order to build that system and connect.
Thank you, Margaret. That was great. Another question, as we're kind of thinking about doing this work with diverse communities. So
Yes.
how do you ensure trauma-informed care works across diverse communities? And I know you said you're doing some expansion in the next couple of years. So just as you're thinking about that, what is your intention, or how do you do that, especially
Absolutely.
across those communities?
Absolutely. And that is has always been important to the center to ensure that or the program, to ensure that any of the models we use have evidence that cross a diversity of people and needs. So whatever community, whatever area, that there's been enough studies done that the evidence shows that it will benefit everyone that needs it in the community. And that's part of how we evaluate any model that we disseminate at the center. And we continue that. We maintain relationships with all of the developers of the model, and they continue, to update that research. And for most of the models, it is sort of a two-way street. If we see anything in our work or our data, we share that with them. We also sometimes get, currently, we're working with South Carolina, MUSC, in a Duke Endowment grant to look at our TFCBT data with South Carolina, years worth of data to look at outcomes across diverse groups and areas. to see if outcomes differ across North Carolina, South Carolina, and across communities. So that is really important to us to ensure that that is part of what we do in disseminating any model. And I think I think there are, barriers to that sometimes, and that is what we're trying to work on. Again, DCFW gave us some funding. We created a pathways model, which allows us to do some scaffolding to agencies that have never trained in an evidence-based model or are struggling trying to implement an evidence-based model and are in a rural or underserved area. And it actually also comes with a stipend for the agency or practice. And so we started that last year. We've had, I think at this point, we're up to about 18 agencies across the state. It's focused on cognitive processing therapy, trauma-focused cognitive behavioral therapy, and problematic sexual behavior cognitive behavioral therapy. And then any funds that any of the MCOs or insurers can put into training and or increasing rates for providers allows more access and the ability for people across the state to be able to train and provide these models.
Thanks for sharing that. And that really sounds like there's a lot of intentionality in the work that you're doing and looking at the data and making sure that it works for all of North Carolina, and what's working in other states can also be replicated here, because we know that we got 100 counties and it's a big state.
A wonderful state, but a very big state.
Yes, yes. Well, thank you. I do have another question that just popped up in the chat or in our Q&A feature. So is the CECERT model only appropriate for licensed clinical providers, or could it be effective for programmatic mental health coaches who serve ECE classrooms with children using challenging behaviors?
That is so, yes.
We got some really smart people in this space. And so I just love that
I love it. These are wonderful questions. And yes, I think so. Dr. Miller really is very thoughtful about how the model can be used and believes, I think most of the data collected and most of the work has been with licensed mental health staff, but they have been using it more and more with DSS staff, some hospital staff, and then collaborative staff. I know there's been some trainings with law enforcement and mental health staff that they've used it for, I believe. There's a couple of articles. One of our trainers at the center, that's CTP staff, just published an article. I'm happy to share that about some of the CSERT training that we've been doing. But yes, I think that it absolutely can. I think we have tended, because of the mission of our program, to focus on the clinical mental health staff, but we've had more and more requests and have been training more and more of the whole staff. So administrative staff, executive directors, and in fact, in our pathways project that we received additional money for, Dr. Miller and one of the other CSERT national trainers is developing with us an executive CSERT. That's a very shortened overview and several consultation calls for executive level staff, HR, intake, to help with the dissemination of CSERT at the agency level so that executive staff can be supportive of the clinical staff and the direct service provider staff in secondary traumatic stress and burnout. So absolutely. And in fact, some of our trainers from our Sparks model and our bounce back model have said exactly that. And I believe some of the trainers from the schools or the clinicians and those that are trained at the schools have attended our CSERT training. So absolutely, it can be versatile.
That's great. and really incredible to know that it can be versatile in that space. And I think that if there are any resources that you want to share afterwards, any articles or anything, please let me know. Please send it to me and I'll send it out to all the folks who joined us or signed up to join today and might have had a conflict. Truly, because I think the more that we can share this information, the more that we can support each other in this work is really what is going to move the needle for sustainable change for children. So I don't have any other questions in the chat. I just want to kind of give last thoughts. If there's anything that you would like to, anything you want to share, any closing remarks, but we are seeing in the chat that folks are finding this to be really helpful and a great, rich conversation.
Super. And thank you to everyone on the call, and Cassandra, our interpreters, thank you so much. I can get you the information about upcoming trainings, the articles, and please, if we can get the word out or share with anyone or meet with anyone, we would love to do that. And thank you for all the work that you all do across the state and for children, for families. We so appreciate it and so glad to be working with everyone.
Thank you so much, Margaret. And for all the folks on this call, thank you for joining us. Thank you for being a part of this discussion. And keep an eye out next week for the follow-up materials from Margaret from NC Child. And thank you for supporting Early Well and the initiative and the work that we're doing overall. So everyone have a great weekend. Thank you.